So I'll just show you, run you through a few of my own cases, which actually I've just picked it up for the last 1 week. Scenario, this is an elderly gentleman who was very active. In fact, he kept asking me, why did I get this problem? He had no coronary risk factors, came with retrosternal chest pain, fairly stable patient, hemodynamically stable. And the EKG, if you look at it, somebody would say, okay, there's some minor TV changes, the lateral leads, maybe a little bit of R and V1, but then really not diagnostic of STEMI. Many people would, but then this patient actually wasn't a casualty. Somebody had the right idea of sending for a troponin T when I actually came in there and I took him up. And that's what you see in the echo. You can see that the anterior wall, this is a parasternal long axis, it's moving very well compared to the posterior wall, little less. So I think the important thing is that there was a subtle, if you look at this area, there was a subtle hypokinesia of the posterior and inferior wall, which was very suggestive of an acute coronary event. Within no time, we got the troponin, which again confirmed the diagnosis. So that's all what is required. And then, so this patient, as a routine in our place, they keep repeating the ECG after 1 hour, not much of changes. But then within an hour, all this investigation ready, and the patient was in the lab, and that's what you could see. This patient, what you see here, this is a left main. That's the one which goes to the front, which is called the left anterior descending. And the one going to the posterior, which is the left circumflex, was totally occluded. You could see the left anterior was okay. So this actually confirmed the diagnosis of a posterior infarct. And the right coronary, what you see on this side was the right coronary was fairly all right, normal. He had some minor disease in the PLV branch, but otherwise it was normal. And so this patient actually had a infraposterior MI, had an angioplasty and did very well.